Hi, everyone. I'm Dr. Emily DeSantis. I'm with Sagis Diagnostics, and my colleague, Dr. Alison Messer, and I would like to share some spooky cases with you in the spirit of Halloween. So I hope you enjoy them, and we'll get started. Our first case is a 28-year-old man who presented with a history of lichenified papules and erythematous patches involving a tattoo on the right forearm. The tattoo had been present for about 5 years, and these papules appeared several weeks prior to the clinic visit. The clinical impression that we received was rule out contact dermatitis or atopic dermatitis versus other. And in a tattoo, you could consider other processes such as a lichenoid tattoo reaction or sarcoidosis. So those were some things that we were also thinking about when we reviewed the slide. And in this clinical image, you can see that there are papules, scattered papules throughout the black ink of this tattoo, kind of following along the ink pattern. Some of the papules are coalescing into small plaques, and the red ink at the left of the image appears somewhat uninvolved. Histologically, the lesion shows epidermal papillomatosis with hypergranulosis and overlying hyperkeratosis. And in the dermis, we can see some black pigmentation consistent with tattoo pigment. In the images on the right, again, we see the papillomatosis and hyperkeratosis and a suggestion of koilocytosis in the superficial keratinocytes. So we have hypergranular koilocytes with some clearing of the cytoplasm as well. So our diagnosis was verruca plana, or flatwort, in a tattoo. So this caused us to wonder if this is a common phenomenon that can diffusely involve a tattoo, or how often this occurs. So infections involving tattoos are typically bacterial infections, such as Staphylococcus and Streptococcus. And with the increased use of sterile techniques in tattooing, the rate of infections has decreased significantly. Verruca plana is a rare tattoo-related complication, and it's usually caused by low-risk HPV types, including type 3, type 6B, type 10, and type 28. The mechanism of infection is not entirely clear, but it's felt to be related to HPV being inoculated through either contaminated ink, contaminated instruments, saliva of the tattoo artist, or possibly a pre-existing wart within the tattooed area. Interestingly, the latency period between the time of the tattoo and the appearance of the warts can be very variable. It can range from a few months to several years, up to about 10 to 15 years, with a mean latency period of 5 years. And also, interestingly, as in this patient, the warts are usually localized to black ink. Black ink appears to have a 7 times higher risk of developing warts than other color inks. And it's thought that due to the chemical composition of the black ink, the ink may actually produce a greater number of reactive oxygen species that will increase the risk of infection. So treatment for diffuse verruca plana in a tattoo can be a bit tricky. Destructive techniques are generally not ideal due to the cosmetic effect. So a variety of topical treatments can be tried, including liquid nitrogen, topical 5-FU, topical 5% imiquimod, tretinoin, salicylic acid, and glycolic acid. So when advising patients who are considering tattoos or patients who have tattoos, it's important for patients to know that those with pre-existing dermatoses, such as lichen planus or psoriasis, are always going to be at an increased risk of adverse reactions to tattooing. And in addition to that, patients with a history of warts may have an increased risk of tattoo-related infection. And the warts may actually occur years after the tattoo is applied. So patients should only ideally visit licensed tattoo artists at licensed tattoo parlors. And while this may not eliminate the risk entirely, it will hopefully mitigate against more severe reactions. So now I'm going to pass this over to my colleague, Dr. Alison Messer, who will present another interesting case.
Hi there, I'm Alison Messer. I'm here to present the other spooky Halloween case. So we've got a 35-year-old man coming in first time for a skin cancer screening. And he reports that the reason he's in for skin cancer screening is because he has a family history of a first cousin who had recently passed away from stage 4 melanoma. So on exam, he had multiple well-demarcated brown macules, papules, and a few pink papules. And these were biopsied. So here is a representative image because a lot of the pathology for all 3 lesions is very similar. So we see a dermal melanocytic process in here. At this low power, it's kind of difficult to discern what's going on with these melanocytes, but there is a little bit of packing of the melanocytes. They're just kind of dense and it's a little busy in here. So if we zoom into really high power, we'll see that there's actually a significant amount of pleomorphism between all the melanocytes. You can see with the blue arrows, these are kind of more what we would call like less atypical melanocytes, kind of a normal size. And then you can see even in this kind of high power field, we have multiple of these very, very large melanocytes with very, very atypical nuclei and actually very prominent nucleoli, which sometimes can be a feature of melanoma. However, importantly, we don't actually see any mitoses within the dermis. So we ended up doing special staining on this patient just because he's young and he had 3 very concerning lesions without any, mitoses. We obtained BAP1 staining. BAP1 is a tumor suppressor protein that we'll talk about a little further, but this patient actually has near total loss of BAP1 nuclear staining. So you can see these blue nuclei. They should be staining dark brown, kind of like down in here, but you can see there's just kind of some cytoplasmic blush. That's not considered positive. We would need to see dark brown within all of these blue nuclei, and we're not seeing that. So it has loss of BAP1 staining. So we diagnosed this patient with BAP1 and activated melanocytic tumors. So all 3 lesions demonstrated loss of this BAP1 protein. We used to just kind of sign these out as atypical Spitz tumors before this mutation was identified. Usually we would call them like epithelioid dermal Spitz tumors, but now whenever these are recognized, we do try to obtain the BAP staining to see if they fit in this category. A lot of times they appear to be innocuous, such as in this patient. He's a young, healthy guy, and beyond his family history and his concern, a lot of times a lot of people may not have biopsied lesions. They're very well demarcated. He's got several of each of them on, his body. There's no clear outliers. He's kind of got these 2 distinct populations. They weren't symptomatic in any way, that the patient just kind of wanted them removed for his just concern with family history. And I believe one of these pink papules did feel a little more indurated than you would usually feel in like an intradermal nevus or like a neurofibroma or something you might be considering clinically. So that could be helpful. They're typically relatively small, average about 5 millimeters in diameter. And the important thing about these is they may be the first and most common manifestation of this BAP1 tumor predisposition syndrome. So this gentleman actually had 3 of these tumors. So because he has 2 or more of these BAP1 tumors that's confirmed with testing, and also because he's had one of these plus a first or second degree relative, presumably with one of these, we actually had him undergo genetic testing, and he was found to have a germline variant in BAP1. So this is a list of some of the other tumors besides tumors that occur in the skin that you might see in this predisposition syndrome. So you can see uveal melanoma, malignant mesothelioma, cutaneous melanomas, renal cell carcinoma, and actually basal cell carcinomas. And one thing I just want to point out in terms of considering these patients for testing, if a patient just has two, melanomas or two basal cell carcinomas, and they don't have any testing that shows loss of BAP1, those would not be patients that are candidates for testing. It really needs to be these BAP1 inactivated melanocytic tumors, or maybe they have one of those, plus they've been found to have like a renal cell carcinoma or something else that also is BAP1 inactivated. And this is just guidance on how to manage these patients. Here's kind of what we recommend in terms of the skin manifestations. So these patients are usually recommended to start undergoing at least annual skin cancer screening, full body skin exam. Some references will actually say every 6 months by a dermatologist, because some of them may have hundreds of lesions and may not be pragmatic to be able to shave or excise all of these lesions. Total body imaging is recommended, and that's what we kind of have considered for this patient. Any lesions that appear to be these BAP1 inactivated melanocytic tumors could be excised. However, that's kind of debated due to this patient's clinical concern. He is actually going to undergo excision of all of these lesions. And then, of course, any of other melanocytic lesions or basal cells just per normal treatment guidelines. And this just kind of follows the other non-skin tumors that these patients might have and how to involve them with other specialties and what they should be doing and how frequently in order to screen them for this condition. And that is it for this presentation. Just remember, with family history and maybe the more indurated appearance of some of these might guide you towards biopsying and diagnosing this condition. All righty.